I'm Jenny Reindorp, I'm Interim Director of Programmes at NHS Providers, and welcome to all of you to this Delivering with Partners session supported by BSI on how we can fix healthcare's biggest tech issue. It's going to be focusing on the really important issue of how we can make better use of data, and I know you'll all be aware of how critical that is for enabling better care, improving health outcomes and delivering more efficient services. And we're going to look in particular this afternoon on how to overcome the interoperability challenges to establishing integrated electronic healthcare records. So I'd like to introduce our two speakers today. I hope everyone's managing with the headphones. It looks like you are. First of all, we're going to hear from Professor Michael Miller, who is a professional programme director in organisational and digital technology transformation and system architecture, programme management and governance. And Michael has worked in healthcare transformation for NHS England, for the Supreme Council of Health in Qatar, in Queensland Health Australia, and for Ministries of Health in many other nations. And then we're going to hear from Angus Metcalfe, who's Managing Director for the global healthcare sector at BSI. Before joining BSI, Angus was Commercial Director for the BMJ, and prior to that, Senior Vice President for the Pharma Division of Thomson Reuters. So without further ado, I'm going to suggest we dive straight in and ask Michael to kick off. So Michael, over to you.
Thank you. Can you all hear me? Right, today's presentation is entitled How Can We Fix Healthcare's Biggest Technical Issue? And that is addressing the issue of semantic interoperability. There's a brief bio of myself. I work for the WHO as an e-health expert and for one of their standards committees in Europe, as well as being an advisor for the 40 New Hospital programme, and I've worked in NHS England on some of the largest projects in the world and all over the world in various countries, as you can see. So let's begin. The standards and structure to deliver a cost-effective, high-quality e-health system. Healthcare systems around the globe are challenged by increasing demand and demographic changes in population. Most populations are ageing, and consequently the demand increases. The fiscal sustainability of healthcare provision is now in question, and I've got no doubt we'll hear more from the Chancellor on Thursday. Chronic conditions, non-communicable diseases, now account for the largest element of healthcare expenditure worldwide. And we'll come on to look at that in a little more detail later on. The need for an integrated care, a more efficient and effective integrated e-health system capable of delivering a single, unified patient summary record has never been greater. The patient-centric integrated care model. There is a trend around the world to move from a fortress-like structure of primary health care, acute care, hospitals, and mental and social care. Facilitate to an integrated care model that is patient-centric, and the diagram on the right seeks to demonstrate that. We are moving into a world of healthcare without walls and healthcare without borders, and I think we see large American corporates like Amazon and Oracle Cerner, and in China, Huawei and Ubisoft moving down that road very, very quickly. And I think perhaps we need to improve our performance in Europe and in Britain. Predict and prevent poor health model. For years, we have known that we should be moving away from a system that prioritises treatment to one that can also predict and prevent poor health. To be successful, this requires integrated patient electronic healthcare records so that any clinician or allied professional can view a single unified patient record at any opportunity. So how have we been doing? The genesis of the electronic medical record. In March 1968, a paper authored by Dr. Larry Weed was published in the New England Journal of Medicine entitled Medical Records that Guide and Teach. The paper is widely accepted as the genesis of the electronic medical record. And Weed in that paper suggested that what we needed to do was to ensure consistent use of clinical terminology. Sadly, over half a century after its publication, no nation in the world has yet delivered a fully integrated, unified, summary patient electronic medical record. As Einstein said, to continue to do the same thing and expect a different result is the definition of insanity. As an example, it is estimated NHS England has spent the last 2 decades and 30 billion sterling on an integrated single patient record. We have still, unfortunately, a significant way to go. And even in the latest government's strategy, the costs and the timescales are undefined. Let's consider the following. What is required to deliver the standards and structure for a cost-effective, high-quality e-health system to support an integrated care model that addresses semantic interoperability, defined by many thought leaders to be the single largest challenge to producing a unified electronic patient record that spans from womb to tomb? Right, the challenge of semantic interoperability. Let's look at the following issue in maintaining the consistency of meaning across multiple domains. Consider the following list of words: tumour, neoplasm, carcinoma, cancer, malignancy, lump, abnormal growth, mass, proliferative disease. These are all words that we could use to describe what is wrong with a patient suffering from a particular form of cancer. The words all share a commonality of meaning. They are not exact synonyms, however. Some are quite general terms that refer to the central symptom of the disease, a lump or mass, without necessarily carrying any implication of diagnosis. There are also differences between the diagnostic terms. These differences in precision and emphasis occur in medical language because they are features of language in general. We are able to communicate effectively using natural language because we bring enormous amounts of background knowledge and use understanding of the context when we interpret what that make up a sentence, the words that make up a sentence. Many of the communication problems in healthcare occur when people involved do not share the same background. Problems also arise when words are used in computer software without an appropriate context, for example, as labels to define categories. It is increasingly important for computerized patient record systems to be able to identify all patients with a particular condition, say diabetes. Simply searching a record for the occurrence of the word would probably succeed on most occasions, but fail on many others. Consider a search using the word diabetes. This would only detect patients whose diagnosis was recorded using the precise word. This would not detect patients who are recorded as diabetic or, as an example, NIDDM, a common abbreviation for non-insulin dependent diabetes mellitus. It would, however, include patients whose record contained the word in other contexts, for example, suspected diabetes or worried about diabetes or son has diabetes. The challenge of semantic interoperability. Controlled clinical terminologies or coding systems have been developed in an attempt to solve these problems. These include the World Health Organization's International Classification of Disease, currently ICD-11, with around 55,000 terms, and the International Health Terminology Standards Development Organization systemised nomenclature of medicine clinical terms, with around 450,000 concepts as they prefer to use, or terms as we might use. It should also be understood that implementation of these standards can take a considerable amount of time and effort. NHS England has spent 2 decades implementing SNOMED CT and still has a considerable way to go. So if one looks, for example, at the 10 ambulance trusts and 1 ambulance service in NHS England, to my knowledge, none of them use SNOMED CT. However, we need additional vocabularies across the entire domain, including, but not limited to, the Dictionary of Medicines and Devices, or DM&D, which was supposed to be an implemented national standard for NHS England. However, unfortunately, has still not been implemented consistently across the nation. So NHS has produced in September 2021, published a document called DAPB 4013, which is mandating sites to all use a consistent DM&D vocabulary. However, although that's been issued, we have still not arrived. Another example is pathology tests and lab tests. We do not have a consistent naming convention, reference range or units of measure for known lab tests. And consequently, what happens is that when we try and bring that data together for a unified record, we fail. Excuse me. We are not alone in seeking a solution in NHS England. Recent initiatives to address semantic interoperability have been developed in three areas. These are 3 recent innovations that seek to address it. The first is the proposal for a regulation of European Parliament and the Council of European Health Data Space, plus its annexes. The second is Oracle, with its acquisition of Cerner for $28.8 billion. Thinks it can fix healthcare's biggest tech issue. Ellison has outlined the well-trodden problem with the US healthcare data system. Patients' information is siloed, often within individual institutions. The third initiative is the world's first cross-border digital health framework program, shared interoperability standards across Sweden, Denmark, Norway, Finland and Iceland. Let's look at each of those in turn. The proposal for a regulation of European Parliament health data space. The European Strategy for Data proposed the establishment of a domain-specific common European data space. The European Data Space, EHDS, is the first proposal for such a domain-specific common European data space. Remember that any EU citizen is entitled to go to any other EU nation and receive medical treatment. It will address health-specific challenges to electronic health data access and sharing. It is one of the priorities of the European Commission in the area of health, and we've been an integral part of building the European Health Union. EHDS will create a common space where natural persons can easily control their electronic health data. It will also make it possible for researchers, innovators and policymakers to use the electronic health data in a trusted and secure way that preserves privacy. The EHDS will also promote better exchange and access to different types of electronic health data, including electronic health records, genomic data, patient registries, etc. Not only will this support healthcare delivery, services and personnel involved in providing healthcare or primary use of electronic data, but will also support health research, innovation, policy making, regulation, purposes and personalised medicine purposes. Secondary use of electronic health data. And finally, on that particular example, an EHR system shall allow personal electronic health data to be shared with health professionals or other entities within the health system, and between health professionals and patients or health professional portals in a commonly used electronic interoperable format, which includes inter alia data set content, data structures, formats, vocabularies, taxonomies, exchange formats, standard specifications, profiles for exchange and code lists, thus enabling the system to be system communication. Interoperability. An EHR system that should be interoperable and compatible with European infrastructure, set out in this regulation for cross-border sharing of electronic data. So unlike we currently have in NHS England, where trusts can decide whether or not to use a particular vocabulary or taxonomy, what the EU is going to do is actually mandate it from 2030. The EHD will also promote better exchange and access of different types of electronic health data, including electronic health records, genomic data, patient registries, etc. Not only will it support healthcare delivery and services, people involved providing care for primary healthcare reasons. Sorry, I've already dealt with that. Let's move on to number 2. The Oracle Cerner think it can fix healthcare's biggest tech issue. On the 10th of June 2022, just after closing a $28 billion deal to acquire electronic health record company Cerner, tech giant Oracle said it thinks it can solve one of the biggest tech problems in healthcare patient records. The combined companies will create a national health record database that pulls in data from thousands of hospitals, said Larry Ellison, Oracle board chairman and chief technology officer, during a press briefing. Ellison outlined the well-trodden problem with the US healthcare data systems. Patient information is siloed off within individual institutions and can't easily be brought together. That makes it hard for doctors to get information about their patients when they are treated at other institutions. It also makes it difficult to reach teams to do studies on large groups of people. They're often limited to the patient information at the place where they work. But despite Ellison's sweeping promise, Oracle will likely face the uphill struggle that organisations like NHS England face to make this vision a reality. Health IT experts tweeted scepticism in the wake of the announcement. Experts in health technology and federal government have spent years, if not decades, trying to make it easier for health records held in different institutions to communicate with each other. Let's look at the third of these new projects, the world's first cross-border digital health framework programme. The Nordic region aims to be the most integrated healthcare region in the world by 2030, according to the Nordic Council of Ministers. A shift towards a digital health and its focus on self-management of health by Nordic populations will be an important step on this journey, but it also brings new risks. Despite the 350,000 digital health technologies on the market, no standardised regulation or risk management system is in place in any of the Nordic countries. This has left medical professionals unable to find and prescribe digital technologies safely. To resolve this critical issue and lead the world in adopting connected health technologies on a large scale, the Nordic Health and Evaluation Criteria, NORDEC programme, has been created. The NORDEC is the world's first programme to unify digital health standards across multiple countries, delivering safe digital health across Sweden, Denmark, Norway, Finland and Iceland. So now let's look at what standards we might develop in NHS England and across the world that could assist and give the necessary standards for semantic interoperability. There are clearly a number of standards that need to be developed if we are to address the largest issue facing e-health sectors. They include a global, comprehensive, end-to-end clinical vocabulary, including but not limited to diagnostics, pathology, diagnostic imaging, and dictionary of medicine and devices, overcoming the challenges of semantic interoperability. Let's not forget that NHS England has spent the last 18 years implementing SNOMED CT, and it's still not been achieved. Number 2, international training for clinical vocabulary, implementation and support. Regulation to ensure adherence, so that trusts are not left to decide which vocabularies or terminologies they use. It becomes a requirement that's regulated. The same can be said for global medical devices and the approval processes and procedures. Perhaps subsequently, as an example, we might progress into genomic data, clinical best practice, individualised care pathways, AI standards including clinical alerts and patient segmentation on the basis of risk, and computerised physician order entry, CPOE order sets. Further areas of standard. Healthcare is a complex domain. Optimal use of data has many benefits, both in terms of clinical outcomes and organisational efficiency and effectiveness, whilst minimising errors and making the best use of scarce clinical and allied professional staff resources. We're aware, right across the world, healthcare systems are short of clinicians and nursing staff. Clearly, data and standards play a key and fundamental role in organisational progress. With chronic disease, lifelong conditions growing exponentially worldwide and being the largest area of cost, for example, diabetes, with patient numbers worldwide set to grow by 46% by 2045, according to the International Diabetes Federation. Further areas of standard development could include patients taking ownership of their own conditions, segmentation of patients on the basis of risk, using resources to prioritise in a prioritised manner, so that we could, for example, in the case of diabetes or chronic disease, identify those patients most at risk from an acute complication and put our efforts into them, because the likely outcome of an acute complication in the case of diabetes, stroke, cardiovascular disease or amputation are expensive for the health provider, but also life-changing for the patient. So we need to target our resources in the most effective and productive way. Sorry. Okay. So we might be involved in the development of standards. What is needed is bringing together representatives of interest groups that might include, for example, NHS Digital, the BSI, the national provider, NHS providers, European Commission, HIMSS, World Health Organization, IHTSDO, and a number of potential suppliers. I think if we do that with the BSI, who are used to bringing organisations together to get a consensus of approach, we have the opportunity to develop standards that facilitate interoperability and deliver maximum benefit for the patient and significantly reducing the cost. Thank you very much for your time today. Thank you.
Role of BSI before we finish.
Thank you, Jenny. I'm just conscious of time. You've been very patient, and to be frank, Michael's done a great job in outlining where BSI wants to play a part in this. So I'm not going to go through my deck. Anyone who wants to explore this, I'm assuming slides are available afterwards. I'm basically positioning BSI as a unique organisation in the midst of this ecosystem. We have no axe to grind, no preconceived ideas, no personal gain from this. We're an organisation that's been around for a long time, creating standards and certification systems off the back of those standards. But I think it's the ability to convene ecosystems and drive for consensus across a disparate group of those stakeholders where BSI can play a part here. You know, Michael talks about some of the challenges that have been around for a long time, and we've got a great experience of bringing the right people together to drive best practice and agree on a consensus-based approach to best practice, developing standards and schemes off the back of it. So we're delighted to be here. I'm here with my colleagues. We've got a stand just round the corner here if you'd like to come and explore how BSI can play a part in this. And I look forward to taking any questions that Jenny's kindly going to moderate for us, either on what Michael's outlined as far as the significant challenges of data interoperability or a broader set of healthcare challenges where BSI may play. Jenny, over to you.
Thank you very much. Thank you very much, Angus. I'm just checking whether there's any questions that have come through or anything that anybody wants to raise. And I'm going to suggest that we wrap up, but do please approach Michael or Angus if you've got questions afterwards. I'm conscious, Michael, that you might have some reflections on the role of board leaders working on shared records in their systems, and what the opportunities are even within the constraints that we currently have, the funding and the technical constraints, what more board leaders could do. So do ask Michael if you've got questions at the end of the session. I'd like to thank you both very much indeed for speaking. Thank you to BSI for your support for this session. And as you said, there are slides available if people want to read them afterwards. So thank you very much, everybody.